Great. So I know you all heard a lot about NMOSD from Dr. Dumovic and MOGAD from Dr. Graves. So I'll be talking about another big entity that we also consider, transverse myelitis. So transverse myelitis, I often get this question from a lot of patients that come into the clinic when they have any sort of inflammation of the spinal cord and they're referred to our clinic, especially I'm sure you all, many of you are familiar with our transverse myelitis clinic in Hillsborough. So they often ask, well, what is transverse myelitis? And I think it's a bit confusing because it's an umbrella term. It basically includes all of the conditions that can cause inflammation of the spinal cord. And that inflammation can cause swelling of the spinal cord, and that's what causes a lot of the symptoms that we end up seeing in transverse myelitis. So I call it an umbrella term because once we know that there's inflammation in the spinal cord, us as neurologists, we have to figure out what is the condition, what is the disease that's causing that inflammation. So when the spinal cord becomes inflamed, it swells up, and then that can disrupt the messages between the brain going out to the body, and that's what causes many of the symptoms that we often see in transverse myelitis, like weakness, numbness, pain, and difficulty with bowel and bladder function. So inflammation in transverse myelitis can be due to a lot of different things, and I'm going to cover the main ones during this talk, but it can be triggered by an infection sometimes, and we know that infections can cause inflammation or it can cause the immune system to create antibodies that can attack the spinal cord, and that's what can cause transverse myelitis in these cases. And then the inflammation could also be due from an immune system problem. So we heard about NMOSD and MOGAD, but there are other autoimmune conditions that can cause inflammation as well that we will cover as well. So how frequent is TM? Well, when you think about the entire population of the world, it's pretty uncommon. It's actually considered a rare disease. So about 1 and 8 new cases, so let's just say 1 to 8 new cases per million per year. And there are about 1,400 new cases reported each year within the United States. So pretty uncommon when you think of the entire population, right? It tends to happen more in females compared to males. It tends to happen more in the 2nd and the 4th decades of life, but us as neurologists specializing in this condition, we see all ages where patients with transverse myelitis present to the clinic with their first symptoms. We don't know of any genetic predisposition or any specific gene that is passed down from parents to children that can cause this, and there's no particular racial or ethnic risk with transverse myelitis. And 20% of all TM cases happen in children. So this is a study from Sweden, so very, different population from North Carolina, but I like the graph because you could kind of see the distribution of when TM first presents. So in the red, you can see that it is more common in females, and it tends to happen more between the ages of 20 to 30, and then between the ages of 40 to 50, and then it kind of tapers off as people get older, that you can see at the end of the graph. So it's less common as people age. So what causes transverse myelitis? So it can occur for several reasons. It can either be, like I mentioned, triggered by an infection. So infection can cause the immune system to overreact, and then those antibodies that are created by the immune system can attack the spinal cord. So it can either happen either during the infection itself, or once somebody has recovered from the infection, those antibodies are really overactive, and we call that post-infectious transverse myelitis. Very rarely can it happen after a vaccine, but we have seen it before, so I think it's worth mentioning. But all that being said, vaccines are still considered to be very, very safe because this is a very uncommon complication of vaccination. It can happen related to autoimmune diseases, particularly systemic autoimmune diseases where the immune system attacks the spinal cord. So we heard about NMOSD and MOGAD. We also consider multiple sclerosis, and then we also consider other systemic autoimmune diseases too, like lupus, Sjogren's disease, and there are many others that can also lead to TM. And then not related to inflammation, but I think it's worth mentioning that sometimes when people have low vitamin levels, like vitamin B12, vitamin E, copper, that can also cause damage to the spinal cord. So this is something else that we will often try to rule out, or you know, when somebody comes into the clinic and they have a spinal cord lesion, we will often measure these vitamin levels because it can be a cause of damage to the spinal cord. And lastly, an entity called idiopathic transverse myelitis. When we've gone through all of the MRIs, the lumbar puncture, all of the blood tests, and we still cannot find a cause, there is it's thought to be about 30% of all TM cases are, we never find a cause, and we call that idiopathic transverse myelitis. So this is a very busy slide, but just to show you that there are many, many causes of transverse myelitis. I know you probably can't see the text, but I'll try to walk through this. So one of the ways as doctors, as neurologists, that we try to differentiate what the cause of transverse myelitis is the timing of the symptoms. So how long does it take from the first point where the symptoms occur to the worst symptoms that one has. So sometimes all the way on the left, we call that hyperacute presentation, when somebody presents that their symptoms present within less than 4 hours. And most of the time we think that that's a spinal cord stroke, when the first symptoms present and they come on very quickly, and somebody goes from being in their normal state to being very disabled within 4 hours. Oftentimes we think that that might be a spinal cord stroke. So that's kind of one way that we can differentiate that from inflammatory causes. And then in the middle there, when we see a patient who had, we call that subacute presentation, meaning like their symptoms developed over the course of hours to weeks, that usually fits more within like infection, inflammation, because that inflammation builds up over days to weeks. So that's another way that we differentiate what is the cause of transverse myelitis. And then there can be chronic, meaning that the symptoms have been going on for many months and been building up over many months. And sometimes those can be more uncommon causes, like vitamin deficiencies or low vitamin levels. Very rarely it can be a cancer, but these are just some of the ways that we will distinguish what the cause of TM is in these cases. And I crossed out NMO there because we already heard about NMO, but just to highlight that there are a lot of different causes of TM that we consider. So I'll cover some of the infections. So there are many infections that can lead to TM, bacterial infections. Sometimes we can see a bacteria that builds up near the spinal cord. It can put pressure on the spinal cord. So there are a lot of different bacteria that can cause this. Fungal infections as well, parasitic infections. This is much less common, but it can still happen. And typically it happens in people that have a low functioning immune system. They're immunosuppressed already for other reasons. So this is typically the situation where we see these infections reactivate. Uncommonly, we can see viral infections as well, like herpes virus, varicella virus, and others. And then during the COVID-19 pandemic, we did have a number of patients that we saw in our TM clinic that had COVID, had recovered, and then shortly after that developed transverse myelitis. So at the time, it was something that we were seeing more often in the TM clinic. So when it's not an infection, what is it? So again, I mentioned that transverse myelitis can be caused by autoimmune diseases. So there are many, many different autoimmune diseases that can lead to this. So we heard about NMOSD and MOGAD. We also consider that MS is something that can cause transverse myelitis because it also causes inflammation of the spinal cord. And then autoimmune conditions as well, like lupus, Sjogren's disease, rheumatoid arthritis, neurosarcoidosis. There are a lot of them, but this is why when you visit a neurologist for these symptoms, we'll get a lot of different blood tests. And what we're looking for are evidence of any of these autoimmune diseases that I show there in the middle column. And then again, I mentioned post-vaccine myelitis, but this is a very, very rare complication, but I just listed there as well. So a lot of different causes of transverse myelitis. How do we diagnose TM? So there are a few diagnostic tests that all neurologists do when we first see a patient that comes into our clinic, and when we clearly know that they have some sort of exam findings that point to the spinal cord. So first we'll get an MRI of always of the spinal cord, usually cervical and thoracic. And then if there is a thought that we want to figure out if this could be a specific type of autoimmune disease, then we'll also get the MRI of the brain as well, because we want to make sure that it's not multiple sclerosis or another condition that can also affect the brain. So that's why we'll often order both the brain and the cervical and thoracic spine MRIs. And then most of the time, the doctors will refer you to get a lumbar puncture, because that really helps us determine whether there's inflammation in the fluid that surrounds the brain and the spinal cord. And then those blood tests that I mentioned to check for antibodies to look for those systemic autoimmune diseases that I mentioned earlier. So there are diagnostic criteria that were published to diagnose transverse myelitis. The diagnostic criteria that we have are from 2002, so they seem outdated, but we still use those criteria. And just to walk you through this, the inclusion criteria are that the person has to have sensory, motor, or autonomic dysfunction that we would attribute to the spinal cord, not to another cause. Usually the symptoms are on both sides of the body, on the left and the right, but it doesn't necessarily have to be on both sides at the same time. But typically, because the lesion is so large within the spinal cord, most people will have symptoms on both the left and the right. And then we'll sometimes see a sensory level, meaning that there might be numbness at the level where the lesion is in the body. And then we obviously want to exclude other causes as well. So those are the diagnostic criteria that we use to diagnose transverse myelitis. And then, of course, when we look at the MRI that I'll show you here, this is an MRI of somebody with multiple sclerosis, but usually what we're looking for is any sort of lesion within the spinal cord. So this is an example of somebody with lesions in the spinal cord due to multiple sclerosis, and the pattern of these lesions can actually point us towards what the cause is. So if we see a patient who has this pattern where you have like these small lesions kind of scattered throughout the spinal cord, they're less than 2 spinal cord segments, usually more common in the cervical compared to the thoracic, and we call them cigar-shaped lesions, then that could point us more towards MS, and then we would definitely want to get a brain MRI, because MS can also appear in the brain as well. But if we see other types of lesions like Dr. Graves and Dr. Dumovic showed, that could maybe point us more towards NMOSD or MOGAD. So the pattern that we see on the MRI of the spinal cord can really help us point towards what is the cause of the transverse myelitis. So this is just one example of MS. So I have one case study here that I'll just quickly go over. So this is a 55-year-old man who presents with symptoms that developed over the course of 2 years, so pretty chronic symptoms. And first he presented with weakness in both hands, and then presented with right leg weakness and numbness. So this all kind of accumulated over the course of 2 years. So he has this spinal cord MRI, and I tried to point with the red lines to what we see. So this white line that you see there is the lesion. So we consider that that's probably due to inflammation of the spinal cord. And then he has a spinal tap, and we see evidence of inflammation in the spinal cord with high levels of protein. So that can be a marker of inflammation within the spinal fluid. So at this point, we're not quite sure what it is that's causing this. So sometimes if we don't know, then we'll try to look for evidence of inflammation in other parts of the body. So that's why whenever we see a patient with transverse myelitis and we don't know what the cause is still, despite getting the MRI and the lumbar puncture, then we'll get a CAT scan of the chest, abdomen, and pelvis, or even sometimes a PET scan of the body to look for inflammation in other areas. So this person gets a CAT CAT scan of their chest, and we find enlarged lymph nodes within the chest. Then we refer them to pulmonology, and where they get a lymph node biopsy, and there's inflammation in those lymph nodes in the chest, and granulomas, which is a specific type of inflammation. So this person actually got diagnosed with sarcoidosis, which is a systemic autoimmune disease that can affect many different organs of the body, but it can also affect the brain and the spinal cord. And then there's a specific sign that we see there in the spinal cord MRI going from top to bottom called trident sign, which can also sometimes point us towards sarcoidosis. So this is just an example of a specific autoimmune disease that we often see in the transverse myelitis clinic that can cause a TM. So who's at risk of having another episode? So for the most part, most people with TM luckily only have one episode. It's considered monophasic and it doesn't recur again. However, in about 1 in 4 people with TM, they can have recurrence, and they can have another event of another attack of TM. So some of the older studies may have reported higher rates, but it was because they weren't really considering NMOSD or MOGAD at the time. So now we think that the recurrence rate is about 1 in 4. So that second attack is usually much more common in people that have an underlying autoimmune disease that we may not know about. So those are usually the people that are more at risk of having a second attack. So again, this can happen more often in those that have an autoimmune condition. So some of the factors that we look at that tell us whether somebody is at higher risk of having recurrence or having a second attack of TM is their spinal cord MRI. So that can tell us a lot of information. So if we see that there is extensive inflammation, and we can look at that, like if there's a IV contrast going into the lesion and that IV contrast stays there, even when we repeat an MRI about 3 months later, that could be a sign that the person is at risk of having recurrence of TM. And then same thing with the brain MRI. So we'll often get a brain MRI if there are lesions that show inflammation, or we repeat an MRI in about 3 months or 3 to 6 months, and there's still inflammation or IV contrast going into those lesions. That can also be a sign of recurrence or at risk of recurrence. Again, if we get those blood tests and we see any evidence of those autoimmune diseases, that's a person that is at high risk of recurrence. And the spinal fluid test. So we can also look for signs of immune activity within the spinal fluid, and we check a particular test called oligoclonal bands. So if the oligoclonal bands are high in the spinal fluid, that also tells us that maybe this person is at risk of having a recurrent attack. And then again, oftentimes after somebody has had transverse myelitis, then we'll repeat an MRI of the brain and the spinal cord within about like 3 to 6 months. But there are no particular guidelines. This is kind of also just neurologist discretion, basically. So recovery after transverse myelitis, I think we're going to hear a lot about rehabilitation and symptomatic treatment and a little bit during the day. So recovery usually starts within that first 1 to 3 month period. So that's why I always tell my patients it is really important to stay active, and it's really important to go to physical therapy and occupational therapy, because this is like the key critical time where somebody has the most potential to recover from their symptoms. And then, another common question that we always hear is, well, what is the timeline? If there's been no improvement after how many, months or years, then what is the likelihood of improving? So there's no, a guideline for that, but typically we say if there hasn't been any improvement by about 2 years, then the likelihood of improving gets lower. But again, I think it's still important to keep going to PT and prevent more symptoms from developing, and chronic symptoms that we often see in TM. So out of about every 1 in 3 people will recover completely or are left with very, very mild symptoms. Another 1 in 3 people with TM have lasting weakness or numbness, but they still remain fairly independent. And then about 1 in 3 have severe long-term symptoms. So it's very difficult oftentimes to tell who is going to fall in what category. And that's a really common question that we hear in clinic, actually, is what category are people going to fall in? And I think, one of the key things is really getting that physical therapy and that exercise and activity going early on and after symptoms start. So some of the things that can make recovery harder, again, when somebody has a very severe attack and they have very severe symptoms at the beginning, that can make recovery harder. Waiting too long to get to the hospital and not getting treatment, that can also make recovery harder. And then if there's been extensive damage to the spinal cord, if there's a very, very long lesion, a lot of swelling, a syrinx, like I showed here, which is a fluid pocket that can develop within the spinal cord. These are some of the things that can lead to harder recovery. But again, still important to get involved in rehabilitation as quickly as possible. So I'm going to focus more just on the acute and the maintenance treatment, because we're going to hear a lot about symptomatic treatment and rehabilitation and psychosocial support. So when somebody first comes to the hospital and they have numbness, weakness, difficulty using the bathroom, difficulty with their bowel and bladder, we'll first try to figure out what the cause is, right? So we always want to make sure that it's not an infection. So we'll try to rule that out as quickly as possible, because once that's ruled out, then we can move on to treating TM as if it's an inflammation or autoimmune cause. So as long as it's not an infection, then we move on to the typical attack treatment for inflammation. So we use IV steroids or IV methylprednisolone for 3 to 5 days. And usually that could be followed by an oral steroid taper, especially if we don't quite know what the cause is. And I will say that I know Dr. Dumovic and Dr. Graves presented on NMOSD and MOGAD, but oftentimes in the hospital, those labs can take like about 2 weeks to come back. So we're kind of just treating without really knowing the cause at the time. So that's why oftentimes we'll do the IV steroids and then follow that with an oral steroid taper. And if it's a very strong or very severe attack, then we'll move on to doing plasma exchange or PLEX, or IVIG is another option, but typically, if it's a very severe attack, we'll opt for doing plasma exchange. And then cyclophosphamide is, in some cases that don't respond to any of these treatments, could be used as well. And then maintenance treatment. So again, much like MOGAD, where we don't know if the person is going to relapse in the future, we kind of hold off until, we hold off on starting maintenance treatment until we get a repeat MRI, or until we see the person in clinic outside of the hospital once they've recovered. And then we'll make a decision about whether the person needs maintenance treatment or not, depending on their blood test results, depending on their spinal fluid results, once all of that comes back outside of the hospital. And then I'll go through symptomatic treatment just very quickly, because I know we're going to hear about that. But I think one of the key things, and this is what we aim for in the TM clinic in Hillsborough, is that management of TM is really multidisciplinary, meaning we need collaboration amongst all different specialists, neurologists, urologists, if the person has bladder symptoms, MS-trained nurses, physiatrists, physical occupational therapists. We need collaboration between all these specialists, social workers and care managers and pharmacists. And then another thing that I always try to stress is it's really important to have a primary care physician, because oftentimes people with TM can develop other symptoms or other comorbidities that can happen related to TM, so really important to have your primary care doctor as well. And then again, the chronic symptoms that we'll often see with TM are sensory changes like numbness and tingling. Pain, we call that neuropathic pain, can happen, especially in the arms or in the legs. Bladder or bowel dysfunction, characterized by urgency, having to rush to the bathroom urgently, or incontinence. Sexual dysfunction, depression, anxiety, and fatigue. So I know we're going to talk a lot about management of these, so I'm not going to focus on this as much, but these are just some of the symptoms that many patients with TM can have long-term if they don't recover completely. And then I missed these. So spasticity is another important symptom that many patients can develop, and we're going to hear a lot about that as well. So managing sensory symptoms, I'm not going to get too much into this, but again, a lot of patients can have numbness, tingling, or neuropathic pain because of the damage to the spinal cord tracts due to inflammation. So there are no medications specifically to help with numbness, but there are medications to help with paresthesias and tingling or neuropathic pain, and I list them there, but I'm sure we're going to hear about them in a little bit. So gabapentin, Lyrica, Cymbalta, lamotrigine, and others. And physical therapy can sometimes help as well. And then again, we'll hear a lot about the motor complications of TM, bowel, bladder management, so I won't get too much into that in this presentation. So some of the serious complications of TM that I think all patients need to be aware of, especially with the bowel bladder issues, like the inability to empty the bladder, can lead to UTIs. And in some cases, especially if somebody is on a medication that suppresses their immune system, that can lead to the UTI, spreading and cause something called urosepsis. So that's a pretty bad infection that requires going to the hospital and IV antibiotics. Aspiration pneumonia can also happen, especially if somebody has a spinal cord lesion up in the high cervical spine. That can cause difficulty breathing. It can cause difficulty swallowing as well. So that can also cause an aspiration pneumonia. And then there can be pulmonary dysfunction. If somebody is not, getting up very much, that can cause skin breakdown or pressure ulcers, or an osteoporosis is another complication. So again, these are some of the serious complications that, of course, as doctors, as clinicians, we always try to check and make sure that somebody is not coming to the clinic with one of these. So I think it's important to just be aware of some of these complications. And then again, psychosocial support is important. We have a whole session on that in a little bit. And then just like Dr. Graves showed, there are a lot of different organizations too that, like the SRNA, the National MS Society, that also have psychosocial support resources as well. And I'm sure we'll hear about that in a little bit. And I'm sure LaShonda Meadows will talk about our support groups that we have available through the TM clinic. And then there are other support groups as well through the MS Society and the SRNA to be aware of. So this is the team at the Bodford Family Transverse Myelitis Center, where we treat and we see patients that have had any sort of complication or condition that has affected the spinal cord. And I'll take questions during the Q&A session. Thank you very much.